Hello everyone, welcome again to the course on breast cancer management and clinical pathway. My name is Dr. Kelechi Eguzo. Today we will be discussing interprofessional collaboration and multidisciplinary tumor boards. We hope at the end of this presentation that you will appreciate the importance of interprofessional collaboration. You will also understand the value of multidisciplinary tumor boards, which we call MDT, and hopefully we'll get you to understand how to set up a tumor board where you are. Okay, so what is collaborative practice? According to the World Health Organization, when multiple health workers from different backgrounds, like nurses and doctors, provide comprehensive care by working with patients, their families, caregivers, and other providers, other professionals. That is what we call collaborative. And interprofessional collaboration is a partnership between healthcare teams. This is a participatory and collaborative coordinated approach of shared decision making. So this kind of to break this down a little bit, this is like a doctor and a nurse, both of the nurses basically working together to share decision making around the patient's need, but with the patient involved in the whole process. This kind of involves blending professional cultures, what we do as doctors and what we do as nurses, and using that to each person brings their own skills and knowledge to the table to improve the quality of care given to the elements of interprofessional collaboration are one, responsibility and accountability and coordination, meaning that you respect me, I respect you. We are all accountable to the patient and the society. There is also communication and cooperation, and as well as being assertive in terms of being firm and fair on what needs to be done. There's also autonomy, meaning you're responsible for your decisions, and mutual respect. You respect me, I respect you. And also trust. Interprofessional collaboration creates a professional team that is designed to work on the common goal, and that is improving patient outcomes. It is not about who is better or who's best, but what's best for the patient. And it also helps build healthy relationships among different professional groups. That is what we call synergy. And that is key to having interprofessional collaboration. So what are the domains of interprofessional collaboration? The first is communication, and then there's patient or what you call client-centered care. There's role clarification, team functioning or working as a team, and collaborative leadership. And of course, when people work together, there's bound to be conflicts. So there is interprofessional conflict resolution as well as that's one of the domains. And so in terms of communication, you find that practitioners from different specialties involved in breast care communicates with patients and with other professionals in a collaborative, responsive, and responsible manner. These are big words, but I have to break them down. Collaborative is something you're going to hear a lot in this presentation, means working together. Responsive means that you are responding to the needs of the other team members and the patient. And responsible means that you are not just acting in a way that does not take into account what is best for the patient. So some of the steps in achieving these are, one, start by establishing communication principles. You listen actively to other team members, including the family and the patients. I have to keep emphasizing patients because the whole goal of interprofessional collaboration is to provide patient-centered care. This happens whether the patient has breast cancer or whatever condition they may have. And then the other part is communicating to ensure everyone understands the care process and the care decisions. And of course, in communication, you develop trust relationship with the family and the patient and other team members. I mean, it's hard for you to trust me or to work closely with me as a physician if we are not able to talk to each other in a very responsible and respectful manner. Then, in communication, we try to use information and communication technology tools to improve our coordination of care for the patient. We can come back to this later. Okay, so regarding communication, it's been shown that listening and other nonverbal means of communication are very important in building team dynamics. And we get to achieve this through negotiation, consulting with each other, interacting both on the work and out of the job, just because it's about building team. Teams are not just built on the pitch of football, for instance. Teams are built in the training ground, the locker room, and even socially. And of course, yeah, not just interacting, but discussing and debating. Debating not just about superiority, but about ideas that are best for the patient. And again, respectful interprofessional collaboration incorporates full disclosure and transparency in our interactions. Meaning, I tell you what I want to do and hope you understand that, and we have a conversation to make sure that we are on the same page. Now, all team members enact interprofessional communication that is consistently authentic. I mean, it's not like you tell me one thing and I agree, and you go to the patient the next different thing, or the next consultant a different thing. That doesn't really build good communication in an interprofessional team. And of course, the communication demonstrates trust with learners and practitioners, patients, and the family. So, what is patient-centered care? I've thrown this word around a little bit, so I think it's good for us to explain what it is and what it is not. Interprofessional teams integrate and value the input and engagement of patients, their families, and community in designing or implementing services. So basically, patient-centered care is doing something for the patient, but with the patient's input. They say nothing about me without me in it. It is not about telling the patient what to do, but discussing with the patient a best plan of action. That is patient-centered care. So in this, you support the participation of patients and their families as integral partners in making decisions, or even in planning or implementing healthcare services. And then we also share information with them in a very open, understandable manner, and encourage discussions to again enhance shared decision making, and to ensure that appropriate education and support is provided by learners and practitioners to patients and their family members. So this basically suggests that for us to have patient-centered care, we have to support their participation, we have to share information, and we have to make sure we educate them on what we're trying to do. Okay, of course, there's also listening to their needs and shape and their expectations. So, patient-centered collaborative care is a partnership between healthcare providers like you and I and the patients, where the patient has the final say, and that's what I call autonomy again in medicine. So, where the patient has the final say in what will be done to him or her, but of course, with full awareness that you've given enough information about this. Now, in patient-centered collaborative care, patients are seen as experts of their own experience, meaning you can't know better about what the patient feels than the patient who feels it themselves. If they are, of course, if they are, uh, how do I put it now? If they are conscious and are able to express themselves. Okay, the other domain of interprofessional collaboration is role clarification. I guess this is where the challenges we face in the Nigerian healthcare systems then come from, where who does what, to what extent. So, in interprofessional collaboration, practitioners understand their roles and the roles of other colleagues, and use this knowledge appropriately to establish um, care for that is responsive to patients and their families. So, for instance, There are certain things that a doctor and a nurse can each do, setting IV lines, for instance. But in what case would you let one person do it and not the other person? And that kind of role clarification is always very important to avoid conflicts and to foster good team dynamics. So in role clarification, each professional describes their own role and what the other people are expected to do. Sometimes, of course, these roles overlap or they conflict even. And we also get to respect and recognize the diversity of experiences and skills in the healthcare team. So people have different competencies and roles and responsibilities. And you also perform your own role in a culturally respectful way. This is back to the patient-centeredness, where when you're doing delivering the services you are supposed to deliver, you're doing it in a way that is respectful to the patient's traditions or what is expected in society where you're practicing. And then you get to communicate the roles and the knowledge using appropriate language. Yeah. And back to the role clarification, we have assessing others' skills and knowledge through consultation. You kind of ask your team members, okay, well, I know you are the doctor here. What are you comfortable with doing? Are you comfortable with doing, for instance, setting the IV lines or those kind of discussions? It's not like questioning someone's authority, but just making sure you all understand who gets to do what and in what circumstance. And then in the role clarification process, we get to integrate all of these roles, sometimes seamlessly or sometimes some bumps here and there, into a model of service delivery. Because I guess when we clarify our roles and understand them clearly, it becomes less uh, common for us to butt heads as professionals in defining who does what. And of course, practitioners need to clearly articulate their roles and knowledge within the context of clinical work. But in articulating your own roles and knowledge, you also have to respect the fact that other people have roles. So you have to listen to the other professionals and give them the respect they deserve. To be able to work to their full scope of practice, practitioners and professionals or individuals must frequently determine who has the knowledge and skills needed to address the particular needs of a patient at every point in time so that we can use our resources more profitably. I mean, for instance, as a physician, if I see that the nurse I work with can do a good wound dressing, it is not uncommon for me to let that nurse do it so I can focus on other things like reading the chest x-ray for the next patient. That's kind of where role clarification and integrating each person's competence comes in. So in the Nigerian healthcare system, there is a need for interprofessional collaborative practice. So when you look at the Nigerian health system, there are a lot of things that we see. One, there's a shortage of some classes of healthcare providers. For instance, we don't have enough brain surgeons. We don't have enough radiologists in every setting that when you need them, especially in the primary setting, even in the secondary setting. So there is need for us to be able to shift tasks and responsibilities in a responsible and a respectful way. And of course, there are some wait times for for some services in most public healthcare facilities. These wait times might be, for instance, before you get to see a consultant at a teaching hospital, at a very busy teaching hospital, that takes some time because of how many patients he's managing. And so it becomes important for us to practice collaboratively and use use the skills of other providers who can provide similar care. And then we get to the consultant when we must get to them. That way we're able to free up resources as needed. One challenge we face in the Nigerian healthcare system is the low quality of service delivery. This is not saying that we do not have competent hands, but when you look at how we deliver service, how we provide care to our people, it leaves a lot to be desired. And I strongly believe that if we collaborate, it can help us keep us accountable to the care we deliver to our communities and our patients. I mean, let me elaborate on this part of low quality of service. So, for instance, if you're having someone perform a C-section today, and the next 2 days the wound breaks down, and out of 10 C-sections he does, 5 of them have wound breakdowns. That's what I'm talking about. Low quality of service. So you have to. So if we have a nurse working with such a physician, it's important that the nurse kind of helps the physician. They can collaborate to find out what's going on with our wounds that we have wound breakdown. That is what that professional collaboration can do to keep us accountable. And of course, the big one with Nigerian healthcare system is the regular conflicts between doctors and nurses and every other person. I do not want to go into the politics of that, but that's a big drawback against our healthcare system, and I'm hopeful that through our discussion on this topic, we can find ways to move forward from that ugly trend. So there is a need to integrate interprofessional collaborative practices in Nigeria. So in cancer care, how do people actually practice interprofessional collaboration? One of the things we have to understand with cancer care is that it is complex. It requires input from lots of experts, from the radiologists or from the radiographer who does the initial breast scan or mammography, to the radiologist who reads the reports, the surgeon who does the biopsies and does the surgeries, and that it takes a lot of experts to get cancer care going. And the prevalent culture of poor interprofessional collaboration does not help our patients because one, the conflict between different groups makes it difficult, for instance, to have a radiologist and a radiographer working together collaboratively. And that keeps the patient going back and forth and doesn't know who to listen to. And of course, for us as professionals or practitioners, it doesn't help us because one person gets overwhelmed, the other person is not doing anything, and there's a lot of chaos. And hopefully, there's a need for us to develop into multidisciplinary teams of experts to be able to tackle some of these challenges. So let's change the gears a little bit here to talk about multidisciplinary tumor boards, because this is one of the ways that we can actually collaborate as experts. So we call the multidisciplinary tumor boards MTBs. These are largely formal, regular meetings of specialists who are involved in cancer care, and they meet to discuss or review individual cancer patients. This is somewhat different from a clinical meeting, where in a clinical meeting or a journal club, okay, let's say clinical meeting in the Department of Medicine, you have someone presenting on a specific topic, and maybe starting with a case presentation, they go to discuss the topic entirely, the complications and all that stuff, and you get knowledge. But in the MTPs, the focus is a case. So let's say there's a case of a woman who's got breast cancer, and we go through that case, look at the characteristics of that case, and decide on what is best for that patient. That's where it differs. Now there are different ways that this multidisciplinary tumor boards have different they adopt different shapes, and sometimes when you don't have enough experts in the room, you can call them mini tumor boards, and these are often utilized in community or low resource settings, like say if you are practicing at Nigerian Christian Hospital in Aba, where you may not have all the experts like radiologists or radiation oncologists. You can have a mini tumor board and try to integrate these other experts from other hospitals. Okay, so there are different types of tumor boards. One could be a general tumor board where you have experts from different specialties discussing all cancer cases or all types of cancers. And it doesn't matter if they are breast or cervical, they just discuss cases as they come up. And the other type is uh, organ specific, where there might just be a breast cancer tumor board. There are other types like molecular tumor boards, which are these guys are just focused on discussing the molecular biology of the cancer, or genomics tumor board. Now, a hospital can have all these forms of tumor boards depending on their resources and their interests. Now, who should attend the tumor board? What do you think? It's actually meant for everyone who plays a role in the care of cancer patients. So the oncologists, medical or radiation surgeons, radiologists, radiographers, radiotherapists, pathologists, family physicians, anybody who's got a role to play in the care of cancer patients would have to, would have something to contribute to the tumor board. Now, it does not mean they all have the same level of skills or knowledge or competence. It doesn't mean they all have something to contribute to each individual case, but they all have a role to play in the care of cancer patients, and they have a stake on the tumor board. Now, this is this survey that was done and published, kind of presented in the ASCO annual meeting in 2014. It's asked people, why do you attend tumor boards? If you look here, the most important reason why people attended tumor boards is to gain opinion about a case. That is why people came to understand and to gain knowledge about how to manage their own cancer patients. Now, that brings us to the benefits of tumor boards. One, it helps improve diagnostic accuracy. I mean, nobody's knowledge is ever sufficient. By having other experts review your case, it improves the accuracy of your diagnosis. It also helps people adhere to clinical practice guidelines, which is what we are preaching in this course. It enhances patients' care by providing ideas from different experts at the same time. This saves a lot of resources and time. Imagine if you have a breast cancer patient today and you need to get opinion from the radiologist, you need to get opinion from the surgeon, and you need to get opinions from the plastic surgeons. It will be time consuming and taking a lot of resources if this patient has to go to each of these people at the same time. Sometimes they make conflicting recommendations, but if they are all in the room discussing these patients, it saves time and resources. Okay, and the other benefit is that it improves staff education and clinical outcomes. A study suggested that more than 90% of physicians who attended the multidisciplinary tumor board in the UK said it improved their practice. Okay, so how does the tumor board function? In this diagram, you see a sample tumor board. Look here. So you may have a surgeon, oncologist. These are the people in the tumor board, and they collect data and send input about the case to someone who's coordinating the tumor board. In this case, they have a nurse navigator, which we're going to talk about that nurse navigator or patient navigator in another presentation. But the coordinator of this tumor board is a nurse navigator. So this individual collects all the information about the patient and brings them and schedules a meeting. And then at the meeting, the specialists or whoever is involved in the care of this patient presents their own point of view about the patient. So let's say the surgeon or the primary care physician, the family physician, GP who first saw this patient, kind of starts by talking about the case and the clinical data. The pathologist will chime in and talk about what he saw after looking at the biopsy. The oncologist will say, well, based on this biopsy result, no, the radiologist might chip in to say, okay, this is what we saw on mammography or breast ultrasound, and then they now get to make decisions about what is best way to proceed with this patient in terms of treatment or follow-up and that kind of thing. They will decide, do we need more tests or not? Then they reach final decision, and it's documented or postponed to the next tumor board. And then the person who is most directly responsible for this patient goes on to discuss the outcome of the tumor board discussion, the tumor board meeting with the patient. This is a fairly intense way of managing cancer patients, but I tell you, it's evidence-based. It's been shown by evidence that this really improves patient outcomes. Okay, so I have just discussed what happens at the tumor board using that previous slide, and who actually gets discussed at tumor boards. It could be the patient who is newly diagnosed with cancer. It could be a patient who is at risk for for cancer, or people who have complex management questions. I mean, complex management questions in this case could be a patient who has a cardiac failure and has breast cancer, and you're wondering how best do I manage that? That's a kind of a complex case. Okay, so let's move on. And everybody has a role to play in or has something to contribute to the tumor board discussion, as I said before. And so this is kind of going over what I said previously about who does what at the tumor board, So the pathologist presents slides, the radiologist presents the images, and of course, it's not every time that you might have glass slides. You might have these images saved as digital files or something like that. But everybody shares their own perspective and their findings, and that way we get to improve the quality of care we provide to our patients. So that all sounds fine and good. I mean, let's bring this down home, guys. How do we set up a tumor board? Let's say tomorrow. I mean, I've said all these things, and you're like, okay, yeah, this sounds good, Kelechi. Let's get this going. How do I start? Now, to be honest, most tumor boards operate in teaching hospitals or academic centers. So, for instance, in Abia State, you could be looking at the teaching hospital or federal medical center. But then this is because those people have more specialists and potentially more cancer patients. But then even smaller hospitals, not smaller in terms of size, but in terms of staffing, who are independent, can also form their own tumor boards. These are the ones we call mini tumor boards. So I agree. I think there is really a need to set up a tumor board in Abia State or several tumor boards across Abia State. In the following slides, I'll be discussing how to do this. The first thing you need to do is to find a group of professionals who are interested in cancer. So, for instance, you're at an NMA meeting or just some professional gathering, you discuss with people about who would like to join our discussion rounds on cancers. And so, when you found a number of people who are interested, it doesn't matter if they are the professionals or not, if they're the experts or the specialists. So, as you have enough hands, enough people who are interested, the hardest part is to start something. You choose a leader. This leader has to be someone who's locally based, and for instance, you can have a gynecologist, gynecologist, or social oncologist at APSU, NCH, wherever to lead this. Now, this the person who chairs this tumor board, their functions are one, to select the cases to be discussed, and to choose who is going to present the case or maybe present themselves, and to ensure that the meetings are well coordinated, meaning they start on time, they end on time, they are lively, and you protect patients' confidentiality. Then how the next thing is to ensure that people attend the tumor boards, like encourage different people from different hospitals or different departments to present cases so that at least you can get the buy-in of those departments or hospitals. And please and please and please don't make this an exclusive club of certain individuals, because that just automatically puts people off. Encourage different experts to join the tumor boards, from radiologists to GPs to even residents, nurses, social workers, radiographers. Students can even join so they can learn as well. And it's also important to choose a convenient time and to be consistent. In the survey that was presented at this ASCO meeting, people were asked how often do tumor boards meet. You find in question 19, they meet every week in some places. About up to half of the time meet weekly. But then some meets every 2 weeks, some meets every month. Start somewhere. And let's move on. So the fourth step is to devote administrative resources to this. It takes a fair bit of coordination to get this going. So it would be good to have a coordinator, someone who organizes the tumor board. The chair presides over it. Like how do I put it? The chair is the driver. but the engine of the tumor board is the coordinator. They manage the logistics for the meeting and kind of organize the document the discussions, write out the resolutions, and they, for instance, if you have a newly diagnosed cancer case, the plan is forwarded to the coordinator. The coordinator alerts chair or the lead physician about the cases that are up. The chairman decides which case is selected, and once the case has been selected, the coordinator creates a list of patients to be discussed, and kind of decides who starts when and puts kind of does all that groundwork. And so the coordinator chooses a meeting location. He invites people about to come for the meeting and reminds them if there are if you need recording, they kind of provide that. If there is need to organize CPD credits, they look after that. And for instance, if you also need to have the Tumor Board work or you kind of use video conferencing, for instance, Facebook Messenger or something that that people who are outside of the room can get to participate, the coordinator handles all that. And you agree, you must not be a doctor or a nurse to be the coordinator of a tumor board. You can start this by having a school of health graduate or even a hospital secretary to do this kind of things, just like other clinical meetings. Now, the fifth step is to look at the logistics. What kind of things do we need to get a tumor board going? First, of course, you need a place, a host. With this, so let's say a hospital like Absuf in Aba decides to host the meeting, then they will figure out which room are we going to use. And of course, there's need for a laptop. I mean, you can start with individual laptops and maybe borrow a projector from here and there, but those are very important. It's always very important to have audiovisual images for running a tumor board. And if you have photographs of microscope slides or imaging findings in these patients, they're always very helpful. I know these days there are a lot of people coming up with digital X-ray machines, so you can get those kind of images imported into the laptop, and that way you can have quality discussion and training as well. But I understand many people do not have network imaging storage systems, so transporting images via flash drive might be a good way to start. And the other logistics you might need, I alluded to this earlier, would be video conferencing, people who are outside. So for instance, if you don't have a radiation oncologist in Aba or in Abia State and you want someone in ABU's area to participate, you might have a way of setting up a camera and getting that person to connect using anything that gives you video over the internet. So Google Hangouts, Facebook, whatever you think works. Of course, you have to ensure that there's confidentiality by removing patient identifiers. But I must be honest, you do not need everything to be working perfectly before you start. Just start somewhere and have someone on standby, like an IT person, someone who knows more about computers, to be on standby just in case something goes wrong doing this. And then the other step is to promote the tumor board. The chair, the coordinator, members of the board should discuss and promote the tumor board to other physicians around, or other professionals around, not just doctors. So, for instance, you can, if let's assume that there is a chairman who is a doctor and a coordinator who is a nurse, you can each promote the tumor board to your colleagues and say, hey, we're having this interesting meeting and we have this interesting case coming up. Do you want to come join? And you can send out this message by email, text messages, WhatsApp groups, word of mouth. The other thing is to provide food. Food is always good. So if there's entertainment, it makes people feel more comfortable. Drug companies are more or less handy to fund this part of the food. And there are attraction for tumor boards if you provide CPD credits. So let's say you talk to NMA to grant several points per tumor board meeting. That way, people when they participate, they get something else in return. Okay, we are making progress, guys, and we're just getting towards the end of this presentation. Before we end, I'd like to talk about the barriers of running effective multidisciplinary tumor boards. The first is time. People are very, very busy. I mean, busy with your formal work, busy with family and community and a lot of things. And of course, people have a lot of cases to manage as well. So we have to make time for it. Low attendance at tumor boards kill the initiative. I tell you, if you start this and people don't show up, you get discouraged. So we have to find a way of boosting that. And of course, poor communication. I had talked about communication earlier within the team, like people not understanding who is doing what or who takes turn in presenting, who has what, who presents what part in a case. It can it can kill morale. So it would be very good for the chair to be clear about who's going to do what regarding the tumor board. And the other thing that's is a barrier is when you don't listen to what people are saying about the tumor board. So if there's no feedback mechanism for people to share their opinion about each meeting, it will be a barrier in running a tumor board successfully. And it's recommended that you implement a feedback tool probably at the end of every meeting. People take time to fill out a survey online. It's easier, it's cheaper. Everybody has a phone that's smart, a smartphone. Or I can just do it on paper. What did you like about today's tumor board? What didn't work out for you? How can I make things better? Those three basic questions are very important. So the question is, would you consider starting a tumor board today? And in this, in question number 35, people said, would you consider starting a tumor board meeting with whoever is available? Surgeons largely said yes, but radiologists said, I don't know. Pathologists are like, I don't want to lead it. But overwhelmingly, people are interested in having tumor boards. Now, this was done somewhere, I believe, in the Middle East area, and I don't know what the answer to this question would be if it's asked in Abia State today. But I'm assuming that people are interested in having having something like this going to improve the lots of the kind of care we provide to our cancer patients. And so we'll be having a survey to ask you if you want to if you want us to create something like this in Abia and how we can do it. And of course, if you look at question number 34 here, what they ask, what are the challenges or what are the problems of having a tumor board? They say lack of staff, not lack of cases. They have cases and interest, but the staffing is the most important consideration, and we have to figure out how to deal with that. That's where the coordinator comes into play. Okay, so in conclusion, interprofessional collaboration is key to improving and sustaining patient outcomes. The tumor boards are a good way of collaborating, and they provide patient-centered care. They help us adhere to guidelines and strengthen clinical pathways. There is totally a need for us to have a tumor board in Abia State. Using the resources we have today, we can set a mini tumor board. I know we have barriers, but we can overcome them. But that is the end of our presentation. Thank you very much for tuning in today, and I hope you've learned something. Just go ahead and give us your feedback and answer the questions that follow. Thank you.